we go to the next speaker. So I have the honor to present you, if it's necessary, to present him, Guido Pennings. So he's a professor of ethics and bioethics at the Ghent University in Belgium, where he's also the director of the Bioethics Institute Ghent. So in addition to this, he's also affiliated lecturers in several faculties, and he's a member of the Task Force on Ethics and Law of the European Society of Human Reproduction and Embryology. He's also in the National Advisory Committee on Bioethics and the Federal Commission on Research on Embryos in Vitro. So now we will speak about the child, and so I let you this couple of minutes or more. The next half an hour is for you, Guido.
Thank you, and thank you first of all for the invitation. It's a pleasure to be here again. As you can see, I took something which up till now has not been really considered by the previous speakers, which in itself is a surprise, because I took this as a topic because I've been chairing one of the subcommissions in the National Bioethics Committee, and there the whole discussion on social freezing was about the welfare of the child. So I'm quite astonished that this is not, internationally speaking, one of the main concerns regarding social freezing. Now, first of all, I'm going to reveal my starting point, and my starting point is reproductive autonomy. And so I define this here, this is slightly different from what you normally hear, as the right to decide in which circumstances one reproduces or not reproduces. Now, what you can see in general is that parental reproductive autonomy is restricted on the basis of the welfare of the child. We generally agree that people can reproduce whenever they want, up to the point where it might endanger the future child. Now, it will not come as a surprise to see that, in fact, the welfare of a future child is something that is very difficult to measure. But there's even more than that. Even if we would be able to measure this, we would still have the problem that we would have to decide which standard we're going to use to evaluate the outcome. And it's especially about the last part I want to talk today, for the simple reason that I think that this explains quite a lot of the confusion that you will find in the debate on social freezing. People use different standards to look at the same kind of material. So, in fact, there are two large groups that can be distinguished. First of all, you have the impersonal and the personal standards, and each of these subcategories can be subdivided into absolute and comparative standards. I will come back to those later. Now, the impersonal standard is very simply the fact that someone else, a third person or institution, is deciding whether or not you can reproduce. So this can be the government, this can be a doctor, this can be a social worker, this can be all kinds of different people. The personal standards is, again, very simply made by the person, him or herself, looking at her own value system, her own life plan, life circumstances, and so on. So in essence, the question on social freezing relies on one basic question: who decides? And here it's important to distinguish two contexts. Obviously, I will only talk about the ART context, since this is the one that we are involved in now. But one frequently distinguishes between natural reproduction, where people say, we can't do much about that, we've got no control about what people are doing in their bedroom, so in the end, this is not of our concern. And then the whole medically assisted reproduction context, where people say, we can check this out, we are going to be able to evaluate whether or not a woman or a man should be able to have a child. Now, again, not only the distinction between personal and impersonal, but also the distinction between absolute and comparative is important. An absolute standard is the use of a fixed threshold, a cut-off point. I will illustrate all this later on, but so this standard is normally used in combination with the sufficiency principle, And that means, very simply, reproduction is acceptable as long as the level of well-being of the child is above a threshold. So that means it is sufficient. You don't go for more than that. Now, the second kind of standard is a comparative standard, and there you don't use a fixed point, but you use another situation as a standard or cutoff point. And the other situation might be another family type, it might be another point in time, it might be another parental characteristic. Now, this kind of standard is usually used in combination with the maximizing principle, meaning reproduction is only acceptable when it results in the child with the highest level of well-being. For the philosophers among you, this is what is called the procreative beneficence principle. So let me give you an illustration. Anna is 30 years old and she wants to have a child. If she has the child now, it will have 10 units of happiness. If she waits 10 years, the child will have 7 units of happiness. Conclusion? My guess, I think that most people concluded that Anna should have her child now. Now, notice that this is not necessarily following because it depends on the standard you are using. When you use an absolute standard, then the conclusion depends on the height of the standard. If the cutoff point is 10 units, then she should have a child now. If the cutoff point is 7 units of happiness, then she can choose. She can either have it now or she can have it in the future because you are not trying to maximize the well-being. You are trying to have a sufficient level of well-being in the child that will be born. Now, if you use a comparative standard, you will see that you use it in combination with the maximizing principle, and that means that you should have the happiest possible child, and that is, you should have it now. Now, just to show you how this works, because this is an intriguing thing, take this as an example. Vera is 30 years old and wants to have a child. She knows that if she has the child now, it will have 10 units of happiness. If she waits 2 months, the child will have 7 units happiness. Conclusion? I think that most people will be convinced that she should not wait 2 months if this is the difference in degree of happiness of the child. So when you make the difference very small, then the effect on the life of the parent will probably also be very small, and then it seems that it is more acceptable to use a maximizing principle. We expect parents in that case not to harm their child that much just by waiting 2 more months. So let us start in this case with the first category we had, impersonal standard. So when a society intervenes in the reproductive autonomy of a couple on the basis of the child welfare clause, then what exactly is the purpose? Now, generally speaking, we try to prevent child abuse, or at least the raising of a child in very bad circumstances. So in the context of ART, we are going to have the job to try to decide by looking at the couple whether or not this is a couple that might risk their future child. Now, as I told you, this is incredibly difficult. So what are we going to do? We're going to look for markers. And the markers in this case are parental characteristics. So we try to determine which characteristic in the couple sitting in front of us is going to decide whether or not they're going to be good parents. Now, again, same problem as I mentioned before. What is a good parent? Or what is a good enough parent? And although this might look like a trivial question, at the same time it's a very important one, because if you do not know the answer, that means that the door is wide open for all kinds of prejudices to creep in. So, in fact, when you look at the literature, you can find 3 different standards. You have a minimal one, that means it has to be really, really bad for the child before you say no. You can use a maximum one, then the child has to be born in almost ideal circumstances before you can say yes. And then you have an intermediate position, which would be much more adapted to what we normally do in natural reproduction. So the no high risk of serious harm condition. Now, again, depending on whether or not the couple satisfies this absolute standard, you can take action. It has been mentioned this morning. For instance, the court in Italy has decided to take a child away from the parents because it considered that the parents at that age were not able to satisfy the minimal threshold. So the reaction there is that the child is removed from the care of the parents. Now let us then move to the impersonal comparative standard. Now, this one is relatively easy. When you ask people, how are we going to decide about the older parents, we look at the reference point, and the reference point will be younger parents. When we ask about lesbian couples, we look at the reference point, and the reference point are heterosexual couples. So in this case, you look for younger mothers, mainly, and we try to find out whether this would be a better situation for the child to be born in. Now, to be honest, I find this highly remarkable, but when you look at the literature, worldwide, there is only one single study looking at the well-being of children born to older mothers. So only one. So I think that there's an urgent need for more information there. But the point is that this one study found that there is no difference in child well-being. Now pay attention, this study was looking at children to mothers above the age of 38. Whether this would still be true when we talk about women of 45, that is a completely different question. Now, what you can see is that, again, the marker kind of thing, you are looking at the parental characteristics, and what do we see from all the couples? Higher education, more stable relationship, higher income, all positive elements for the well-being of the children, and other things which are still under discussion, like, for instance, the depression rate in mothers. Now, the problem when you use a comparative standard, so you're going to compare to the younger couple, is that you take your reference point as the gold standard. So if older women do not as good as younger women, then you should not treat the older women. So that's your maximizing principle. So that is what you do here. You are going to say, if they do worse, then you should not help them to have children by means of ART, for instance. Now, what bothers me most about the use of this kind of decision rule is that you have to apply this consistently. So let me give you one example, the one I was mentioning earlier. Most likely, we will find out that older parents are as good or even better than younger parents. Secondly, we found out that the evidence we have suggests that lesbian families are better than heterosexual families. The conclusion from this is that young and heterosexual couples should not have children and should not have access to ART. Now, there are not many people who defend this position, but ironically, this is what follows when you start comparing, because the maximizing principle excludes those who do not manage to be at the highest possible level. Second point I wanted to make about the use of this decision rule is that, in fact, we are looking here for characteristics that indicate how good parents will be for the child. Now, we are looking for new characteristics, while in fact there are a number of characteristics which we know from the literature do have an effect on the well-being of children. The first one has been shown in hundreds of studies: parental income. Children raised in poor families are considerably worse off than children in well-off families. Conclusion: poor people should not have access to ART. Again, I don't want to be the one who's going to spread this news, but this is what is following. Second example, having been abused as a child. So parents or would-be parents who have themselves been abused as a child have an up to 50% risk of abusing their own children. How many IVF clinics do check for the history of abuse in the candidate couples? Not that many. So my point is, we have a number of indications. For those we do not use it, and for a number of others we're going to look for indications, and then we are very eager to use them. So in my book, this means that you're probably trying to impose a prejudice on your patients, in this case, a prejudice against older women. So the third standard, the personal comparative standard, so that's a woman looking at her own life and comparing what she has now with how the future will be. So you have different possibilities. If the present is acceptable and the future is acceptable, she can do whatever she wants. You can have it now or she can postpone. The present is acceptable, but the future is better. Then most likely she will postpone. The present is acceptable, but the future is worse. Then probably she should try now. And the present is unacceptable and the future is uncertain or better. And again, she will probably postpone. Now, let me give you a simple example. Mary is 33 and single. She's living in a small apartment and has a low income. Although she could raise a child now, she hopes that she will find a partner to make things easier and better for everyone. So what is happening in this case is, again, very simple. At the time of freezing, she is evaluating her own situation, both at present and in the future, and on the basis of that information, she decides what is going to be done. And in fact, she's going to do exactly the same in the future when she, at a certain point, will have to decide whether or not to use her eggs. So this starts repeating itself as a balancing exercise now and in the future. But the point here is that if you use a personal standard, then you include not only the welfare of the child, but you include all the other aspects that are relevant in your life. So your relationship, as we have heard before, financial situation, housing, personal circumstances, and so on. And the point is obviously that if you allow someone to determine this herself, then you are more likely to have an accurate decision than when you base your decision on one single aspect, which is the age of the mother. And then the last standard, that's the personal absolute standard. Now, we know from the literature that this is also one of the elements that can be used by people to decide when and in which circumstances to reproduce. We have already heard that a number of people have a threshold which says, I'm not going to reproduce without a partner. So these women, when they have at the age of 30 or 43 not find the right person, then they are not going to come back because this absolute standard excludes them from going ahead with their original plans. Now, there's one thing I want to say in the end, and this counts for every single standard when you look at the debate. All the time you can see that you need a rather extreme reduction of the situation as it exists. Take, for instance, age. We talk as if the age is the only characteristic of this woman. And in fact, we are quite familiar with this because this is a problem that people with a handicap have. This person has a handicap, as if this person has no other characteristics than a handicap. So an older woman is old, as if she has no other characteristics apart from being old. So, in fact, why should age, in this case, be the most important element to decide about the well-being of the child? The woman may also be very rich, be able to take a nanny, and a number of other elements that might contribute. Second, and we also heard this, we act as if the woman is the only parent. Now, we know that the man is quantité négligeable, but nevertheless, he must be in there somewhere. So why do we just ignore him? All the time we talk about the woman, but the man, in most circumstances, will also have a say in this kind of decision. Third, we ignore the effects of postponement. And in fact, one of them has been mentioned by Jill Lockwood in one of her earlier publications, the fact of fertility penalties. The fact that a woman who has her child earlier in life will have a much worse career than a woman who decides to postpone, not only in terms of income, but also in terms of the general evolution of the career. This is something we know and something that should be taken into account. And then this is the last thing that is used in the debate. There's a sole focus on the well-being of the child. And the argument there is what you can frequently read for ART, the well-being of the child is of paramount importance. Now, to be honest, I have not been able to find one good ethical reason why this would be the case. I think that everyone's interests are as important. So the child is not more important than the parents. And I think that this is what is generally defended in all ethical theories. So can you imagine what it would happen, of what kind of decision you would take when the welfare of the mother or the parents would drop considerably more than the welfare of the future child would increase? So in those circumstances, would we still defend that the woman should have a child earlier rather than later? And especially since, as I mentioned earlier, we know that having her child earlier will have an effect on other aspects of her life, and all these other aspects will indirectly affect the well-being of the child. So doing good for the mother, generally speaking, would also be doing good for the child. So I come to my conclusion. Even if it were possible to determine the effect of parental age on the well-being of a child, we still have to decide which standard to apply for the evaluation. Second, reproductive autonomy should mean that unless there is clear evidence that a certain decision harms a person in the family, the standards adopted by the participants should be respected. So I'm pleading here in favor of a personal standard. And at the moment, there is no evidence that children of older mothers are worse off. So there is no justification for condemning social freezing for that reason. Thank you.
Please, there are 2 questions over here for the moment.
So, congratulations. I understand that it's the child is a big concern. The well-being of the child is a big concern. The difference between the parents and the child is that the parents choose to have the child never chooses to come on earth. So my question is, what is the responsibility of the parents and what is the responsibility of the team of ART in case of handicap, for example? Is there a responsibility? And are our affair of insurance are going to grow up or not?
Well, I wouldn't know about the last part, but let me make it very simple. I believe that the prime movers are the parents. They go to the clinic with the intention to have a child. So they have the primary responsibility. Then the doctor has to decide whether or not he or she is going to join into the project. So in legal terms, we call this complicity. You contribute to what is happening. And in that sense, the doctor has a responsibility. That, for me, makes the difference between natural reproduction and medically assisted reproduction. So they both have to accept a certain level of risk. But that obviously means that if the doctor decides, for instance, we have had the discussion earlier about women over the age of 50 who would be made pregnant, that the obstetric risk can be too high. So the woman may want that, but if the doctor, from his or her point of view, decides that this is an unacceptably high risk, then he should not help in the process. So it's always a collaboration, whether you like it or not. what you can see is that earlier on, the doctor had more to say in the whole thing, while what we see now is that we get more into a consumerist kind of mode, where it is the patient who is going to decide what level of risk is acceptable. So, but again, I think it's moving in both directions, but there must be some kind of agreement about what is acceptable and unacceptable risk.
Just a quick answer, because I'm focusing on the child. Is the child has any right to attack the parents or the team because he's born? We had a few years ago in France, l'arrêt Perruche. I don't know if you know about l'arrêt Perruche. This poor baby is born with a handicap, and he's not responsible. So the way we resolved the problem, our Minister of Health at this time was to say, it's not because you were born that you have any right. That was the way to say. The end of it, it was the child doesn't have any right to attack anybody.
Yeah, it's the same in the natural life. So you don't have any rights until you are born. You cannot decide before if you will live in a rich family or in a family that you love you, or in another kind of state that we think is fine for a child. So it is not a right for anybody. So that's the problem.
Well, to be honest, the whole issue of wrongful life or wrongful birth is, philosophically speaking, a highly complicated matter. But let me make it very simple. The point is that normally this kind of things should be decided on the basis of good clinical practice. If, according to your peers, something is acceptable, then it would, according to me, it cannot be an issue that the child would challenge or sue anyone if it turns out that he or she is handicapped. There's no way you can avoid this. The only zero risk is no reproduction. So whatever you want, there's always going to be some residual risk left. The only point is, and that's the discussion we're having also regarding social freezing, is where is the cutoff? From which point on would we consider it inappropriate to make a woman pregnant? Is it 50, 55, 60, you can, that is part of the debate now. But that is part of the debate not only for the woman, but also for the child that will be born.
Gillian?
Thank you, Guido. That was very thought-provoking. I just wanted to make one point, that is that 50% of babies are made by accident, no planning, no prior intention. And I've always felt rather uncomfortable that for the couples or even individuals who need our help to do what the vast majority of the population can do without any trouble and without apparently even trying or planning, that they should be made to get above a higher threshold. And I think that here the false analogy is always drawn between choosing a couple to give a child for adoption to and choosing a couple to grant ART to. If you've got competing would-be adoptive couples and you've got one child, I can see that we have a duty to find the best possible parents. But if you've got a couple that needs our help, needs ART, we're not in a position to say they've got to score 95% on the potential parenting scale before we're going to offer them help. And by comparison, if a couple can get pregnant all by themselves, even if they have a life-limiting disease or handicap or they're very poor, usually the state pulls out all the stops to help that pregnancy go well and support them, but we wouldn't normally offer them help to achieve a pregnancy in the same circumstances. And I wondered how you felt we could balance that inequality.
Well, to be honest, I think that exactly the same standard applies in all circumstances. So if you have a couple with a high genetic risk, for instance, 50% chance of having a child with a serious disease, they are not infertile. If they go to an infertility clinic, probably the clinic will say, we're not going to treat you unless you use PGD so that we can eliminate the risk. Now, if this couple is fertile and they just have sex, they might have a child. So what is happening is that the government is not going to intervene in what they are doing for the simple reason that you are respecting the negative right. But from a moral point of view, I think that these parents are wrong. They are doing something morally wrong. Just as you would if you would accept this kind of couple for ART treatment without having measures to bring down the risk. And by the way, I believe the same thing about adoption. I think that the rules in most countries about adoption are just ridiculous. They are applying a maximizing standard for which there is no justification whatsoever. We have studies on embryo donation, we have studies on adoption. Embryo donation couples are not being selected, the children are doing perfectly fine. So what is the whole point? We control it and then we believe that we have to use a maximizing standard. My reaction would be, explain to me first why you use a maximizing standard, and as I've tried to show, this is going to lead to very strange and funny situations. Then we can come back and talk about the adoption issue. So I think that you use a sufficiency standard, and that is what we do for normal reproduction, use the same thing in all other circumstances, ART and adoption included.
Thank you for your presentation. Don't you think that we are leaving ethics to shift towards moral here?
To what?
To moral. We are leaving ethics to set rules which could be applicable to the common couples, because the situation, I have two questions basically concerning the interest of the child to come. Who is qualified to talk about the interests of the child? This problem has been reported for the late fatherhood, and here basically we are in a situation of postponing pregnancy. If she is not using her frozen oocyte, there is no problem. She will have a natural conception. Why use of frozen oocyte should be a problem? I think that this is a private problem with medical implication, and that rules should be a reflection, an ethical reflection. If we shift in moral rules with standards and threshold, I don't understand, and I would like to have an explanation about the threshold and the happiness score, because if there is a happiness score, I'd like to have la recette.
Well, I'm not going to be able to give you one, but at the same time, I don't think this is a real problem. You know, there are literally hundreds of different standardized scales to measure people's happiness. Now, you may have questions about every one of them, but still we are able in general to say something about it. And by the way, we are doing this in a large number of circumstances. Look at, for instance, prenatal diagnosis and pre-implantation genetic diagnosis. The general idea is that you should avoid a high risk of serious harm. The serious harm part is the one that concerns the happiness. We start from the idea that if you have a serious disease or a serious handicap, then we should do something about it. Now, we're not going to be able to say that you have 10 units. I gave the example just to explain how this might be affected. But the point is that even if you are not able to put an exact number on it, we still have an idea about whether or not the child will have a reasonably happy life. There might be a huge gray area, but we still have this idea. And so from the moment that we are involved as a society, and we are through the development of medicine, through the development of reimbursement systems, through the development of healthcare systems, then indirectly the procreation of people also becomes our concern, and that is where ethics then steps in. Reproduction in no society whatsoever is a purely personal thing. It almost not exist. It would also be rather strange. There's always influences from society, and that, according to me, explains why we are discussing and why society is so much interested in what people are doing in terms of reproduction, because society has something at stake. And that is indirectly the right to intervene, just like we have the right to intervene when parents abuse their children. We also think that it's not up to the parents to decide that, but that we have a right to intervene into this kind of situation. And this is very similar. The only problem is that it is prospective, and that makes it extra complicated. How do we know for sure? But this is a discussion we're having about, for instance, drug-abusing parents. Would you treat them? Most people would say, no, we don't, because there's an effect on the children. Heavily handicapped, mentally handicapped parents will not be accepted. Why not? Because we know that they are not doing well as parents. So this kind of intervention, for most people, is perfectly acceptable. The point is, again, from which point on do we say unacceptable, from which point on acceptable? And that is the discussion we are having at the moment.
Thank you. We have 2 more. Thank you, Guido.